Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC. Recently, there have been a couple of high-profile deaths from aortic dissection, and so that's focused our attention again on our ability to make an accurate diagnosis of this condition very quickly, and so in order to treat these patients effectively. We have an interesting paper dealing with aortic dissection and, in fact, aortic syndromes in general. We have the opportunity to talk to the authors of that paper, Dr. Aaron Ranasinger and Dr. Robert Bonser, are respectively lecturers and professors at the University of Birmingham in England, and they published or about to publish a very interesting paper on JACC that deals with biomarkers in acute aortic dissection and aortic syndromes. So tell me, Dr. Bonser, a little bit about the issue of how to make a rapid diagnosis in acute dissection.
Well, I'll preface that by saying that it's a highly lethal condition, and we know that about 20% of patients die before any diagnosis is made. And that in both the USA and in Europe, there are significant delays between the time of symptom onset and the actual diagnosis being made, which can be beyond 24 hours. We also know that about 50% of patients with type A dissection, the more lethal type, do not undergo surgery for more than 24 hours following the diagnosis. And noting the very significant attrition rate of the condition, it's paramount that we try and diagnose it earlier. The way that we might diagnose it is by introducing biomarkers. And there's several candidate biomarkers that have shown promise, but have never been prospectively validated or used in wide practice. And the overall objective is that in time that there should be a biomarker that's available to the paramedic, which can provide a high index of suspicion that a patient may have a dissection, so that they can be directed towards an appropriate emergency center, rapidly investigate it, and proceed to their treatment.
Yes, so Dr. Ranasinger, can you tell us some of the most promising candidate biomarkers that are being evaluated?
There are a number of biomarkers which have been studied, which we've set out in the review article, and they relate to injury to the aortic wall, release of elastin fibers into the circulation, and activation of the coagulation system. And they include smooth muscle myosin heavy chain, calponin, which is a troponin-like component of smooth muscle, as well as soluble elastin fragments. Now, although those have shown promise, none of those biomarkers are commercially available. Perhaps the most readily available biomarker, which is available at the moment to us at this moment in time and in widespread use throughout the medical community, is D-dimers. Now, D-dimers have a high sensitivity for aortic dissection, but a relatively low specificity. So although they are perhaps the most useful biomarker available to us at the moment, they are not perfect. And it may be that there is a panel of biomarkers which incorporates several of these tests, which could be more appropriately used to help to move patients into an early treatment algorithm.
Well, certainly we need to get any biomarker drawn and analyzed and reported faster than we could do one of our imaging techniques, because at this point in time it's fairly easy to get either a transesophageal echocardiogram or CT angio. Does it look like that might be on the horizon in the future?
There are already available and commercially available a number of point-of-care diagnostic tests for cardiovascular biomarkers, and these incorporate troponin, BNP, as well as D-dimers. So there is technology still there available, and in one of the papers in which was cited, they have cited the use of a rapid 30-minute D-dimer analyzer. So there is a technology there available, and certainly within the United Kingdom, we may not be able to get CT scanning as quickly as you can within the United States.
And although, Dr. Murray, if I may say, that although transesophageal echocardiography and CT scanning are rapidly available, they'll only be applied if there's an index of suspicion that there is acute dissection. And that's where clinical practice currently fails and sets in a delay. And so the principle of biomarkers is to introduce the patient to a diagnostic algorithm. They will not substitute imaging technology. But if you have if a patient arises with a panel highly indicative of dissection, they will straight away be channeled into that imaging algorithm and can then expedite their treatment.
Well, that certainly seems eminently sensible. We certainly will look forward to the availability of biomarkers, and I quite agree this is an area where our diagnosis needs to be enhanced and hopefully will be, so that we can treat these patients more effectively. For Inside Jack, I'm Tony DeMaria.